welcome all to the class. So today's topic, we will before we start with today's topic, we will have very frequently asked questions. Okay, uh, if you have read the guidelines, in the guidelines there are two tables which you see. One is level of evidence, and second is a grades of recommendation. We read the whole of the guideline, but most of the time we neglect these two tables. But sometimes there can be SBA or there can be EMQ also on this particular topic. So today's we will finish these questions and then we will go for the today's main topic. Okay, and if you have read the consent, okay, in the consent we are talking about the various risks which are involved in the procedure, in the operative. So that is called as risk information. And the way we describe is 1 in 10 or 1 in 10,000. But when we talk with the patient, then how it is to be spoken, and like common, uncommon, and what does it mean? Okay, so that we are going to see. You maybe ask about the SBA or EMQ on this. Okay, so first we'll see about the risk information. Okay, so whenever we are talking about the information on any risk, what are the terms which are commonly used while talking with the patient? That very common. Then we talk about the common risk. Then we say that it is an uncommon risk. Sometimes we say that it is a rare risk, and sometimes we say that it is a very rare. Okay, so what does this very common mean? When the risk involved is 1 in 1 to up to 1 in 10, that is almost a person in the family is likely to have that particular risk. It is that common. We label this as a very common. Okay, so in numerical ratio, it will be 1 is to 1 to 1 is to 10. Then we have some common risk. Okay, that is described as a in the numerical 1 in 10 to 1 in 100. That is, in colloquial language, it will be a person in the street is likely to have such and such condition. Okay, so same about uncommon, from 1 in 100 to 1 in 1000. That is, in colloquial equivalent is a person in the village. Then rare condition, that risk is 1 in 1000 to 1 in 10,000. That is, a person in small town is likely to have this particular condition or likely to have this particular risk. And when we say very rare, that means the risk is less than 1 is to 10,000. Okay, that is a person in the large town. So these are the things which are commonly asked, used, and they ask you any of this, and they will ask you what does this uncommon risk means. Okay, so this is one of the SBA. Okay, so this table you should know well. Okay, so now we'll have you understood this? 1 in 10,
Yes,
1 in
sir.
1 in 100, 1 in 1000. So very common, common, uncommon, rare, and very rare. So just see this question if you can answer this question.
Yes, sir. During counseling before an elective cesarean section, you explain the risk of accidental bladder injury. You state this is an uncommon complication. Which option correctly represents both its equivalent numerical ratio and colloquial equivalent? Um, yes, uncommon, very common, common, uncommon. It is 1 in 100 to 1 in 1000. Option B, a person in a village.
Uncommon. Okay. So what is uncommon? It is 1 in 100 to 1 in 1000.
1 in 1000 in a village.
So remember, village, generally the village population, small village, up to 1000, a small area where there is a locality, it is up to 1000 population. That corresponds with the uncommon. Okay. Then we have 2 on this side, 2 on this side. Okay. Then after the village, it is a small town. So maybe 10,000 population, and large town maybe less than, the risk is less
10,
than.
1.
Yeah. Okay, it is something like that. So you remember in this particular way. So go for the next question. So the answer for the first question, in operative risk, uncommon means the frequency is between 1 in 100 to 1 in 1000. 1 in 100 is on the street, a person in the street. Okay,
Okay.
and 1 in 10 is a
When
person in the family. Okay, yeah, go ahead with the question number 2.
when obtaining consent for laparoscopic sterilization, the patient asks about risk of fatal complication under general anesthesia. You describe this as very rare. Which option below gives the correct equivalent numerical ratio and colloquial equivalent? It will be D, less than 1 in 10,000, a person in a large town.
Actually,
Very rare.
these questions are very simple, but sometimes we get confused. Okay, that is why I'm covering specifically these 2-3 questions. Now the subsequent topic will be more confusing. Okay, so the answer for this question was a D, that is very rare operative risk occur in a fewer than 1 in 10,000 cases comparable to a person in a large town. Okay, now we'll go ahead with the grades of recommendation. Okay, so first
Yes.
thing, there are two things. One is a level of evidence and second is a grade of recommendation. Okay, so the recommendation will be based on the level of evidence. Okay, so what is the level of evidence? From that we make the recommendation. This recommendation can be graded as a grade A, B, C, D and P or GPP, that is a good practice point. Okay, so these are the grades of recommendation: A, B, C, D and P. Okay, so these are the grades of recommendation. Okay, now what does the grade A recommendation means? This grade A recommendation means this recommendation is derived from at least one meta-analysis or systematic review or RCT which is rated as 1++ directly applicable to the target population, or systematic review of RCT or a body of evidence mainly rated as 1+ directly applicable and showing overall consistency of results. Okay, so here when we talk about grade A, what do we mean? It is based on the SR and MA. Think of systematic review and meta-analysis. Think of RCT, which are graded as 1++ or 1+. Okay, so this evidence is coming from the uh, either systematic review or meta-analysis of RCTs, which are graded as 1++ or 1+, directly applicable and showing the overall consistency of the results. Okay, when we talk about the grade B recommendation, it is based on the body of evidence including the studies which are rated as 2++, directly applicable to the target population and showing the overall consistency of the results, or it is extrapolated evidence from the studies rated as 1++. Doctor, can you unmute yourself? Dr. Sinchana, can you unmute yourself? So body of evidence, so grade B, the body of evidence including the studies which are rated as 2++, directly applicable to the target population and showing overall consistency of the results, or extrapolated evidence from studies which are rated as 1++ or 1+. Okay, so grade A is directly 1++ or 1+, and it involves the meta-analysis or systematic review of RCTs. Okay, while in grade B, what we have, the studies are rated as a 2++. Okay, or it is extrapolated from 1++ and 1+. Okay, so it is either extrapolated evidence from this or it is coming from 2++ studies. Okay, now grade C, that is the body of evidence including studies which are rated as 2+. Okay, remember here it is coming 2+. So when it comes A, both are there, 1++ plus 1+ is there, while in grade B we only have 2++ and extrapolated from this. Okay, 1++ and 1+. Then in grade C, what we have, in grade C, what we have, only 2+ and extrapolated evidence from 2++. Okay, then grade D is evidence level 3 or 4 or extrapolated evidence from 2+. Okay, and P stands for good practice point, recommended best practice based on clinical experience of the guideline development group. Okay, so it is a recommended best practice based on the clinical experience of the guideline development group. That is labeled as a P. Okay, so how to remember this? When we talk about A, that is the strongest evidence and it will be based on SR or MA of RCT, which, and we will have 1++ or 1+ studies. Okay, and directly applicable with a consistent results. So these are the key words you remember. Grade A is the strongest evidence and it will depend upon SR or MA from the studies which are rated as 1++ or 1+, and it is directly applicable to the population having the consistent result. Okay, next level is a grade B. It is a high quality cohort or case control studies which are rated as 2++, or it is extrapolated from grade A evidence. Okay, so here studies what we are getting are the case control and cohort. So here they were RCTs, here we are getting case control or cohort. They are labeled as 2++, and it is extra, or it can be extrapolated from this. Then next is a C, that is a moderate level of evidence we have, which is again case control or cohort, but these are 2+ studies or extrapolated from the this particular 2++. Okay, then we have grade D, that is the lowest, either case series or reports, that is level 3 or 4, or it is extrapolated from this. Okay, then we have P, that is practice points. That is how you remember. A has got SR and MA of RCTs 1++, 1+. B will have SR and MA of cohort and case control studies. Okay, but the studies are 2++ or extrapolated from here. C will have only 2+ or extrapolated from 2++. The D is the lowest one, that is case series and case reports. Very easy to remember. D is the lowest, case series and case reports, or it is extrapolated from 2+. So when they ask you about D, no, don't select the option with case series and case report. You select completely. So this extrapolated from 2+, you may have two options. One is a case series, case reports, level 3 or 4, and another option will be this complete sentence. So this complete sentence you should remember. P is practice point, what we have discussed. Now how to remember? A simple mnemonic to remember the order is all best care delivered promptly. Okay, you can note it down in your notes later on. Okay, A is a top, which involves RCT. B is the next best. Okay, B stands for best. So after RCT comes this case control and cohort studies. Then 2++ we have, and here it will be 2+, and it will always be extrapolated from A+ will be in the B, extrapolated from 2+ will be in the C. Okay, sorry. And D is the lowest one, that is level 3, level 4, or extrapolated from 2+. Okay, so that is how you should remember. So now coming to the evidence grading in clinical guidelines. So here Dr. Sinchana, can you read these two questions?
Yes, sir.
Yeah.
STEM 1. A guideline statement says this recommendation is based on body of evidence, including study rated as 2++, directly applicable to target population and showing overall consistency of results, or extrapolated evidence from studies rated as 1++ or 1+. Which grade of recommendation best fits this statement? This is
These are
grade. Um, it is grade B studies. Either it is studies directly rated as 2++, directly applicable, or extrapolated from 1++ or 1+.
correct, correct. Okay, next.
STEM 2, a guideline statement says the recommendation is based on body of evidence, including studies rated as 2+, directly applicable to target population and showing overall consistency of results, or extrapolated evidence from studies rated as 2++. Uh, this is a grade C recommendation.
So option C. Okay,
C.
so yeah, but when you see all the options, you are likely to get confused. Okay, so that is
Yes,
why
yes.
make a habit of understanding the concept very clearly. Okay, so the correct answer is B, and here correct answer is C. Okay,
Yes.
now we'll go ahead with the level of evidence or the classification of evidence levels. Okay, now how the evidence levels are classified? They are classified as 1++, 1+, 1 minus, then 2++, then we have 2+, 2 minus, then 3 and 4. Okay, so now simple, we'll learn first 3 and 4. What are these 3 and 4? 3 is non-analytical analytical studies, that is case reports and case series. Very simple to remember. Case 4 is just an expert this level 4 is an expert opinion. Okay, now here we have to remember this 1++, 1+, 1 minus, 2++, 2+, and 2 minus. So these are the things we should remember. Okay, now what does 1++ means? It is a high quality meta-analysis or systematic reviews of RCT or RCT with very low risk of bias. Okay, so we have RCTs high quality with very low risk of bias. Okay, 1 plus. Then 1 plus what we have, well conducted meta-analysis and systematic review of RCT. Again, we are talking about RCTs only, but low risk of bias. Here it is a very low risk of bias. Here it is a low risk of bias. Okay. Then we have 1 minus. Again, we have meta-analysis or systematic review of RCTs, but we have got a high risk of bias. So when we talk about 1, as such, we have common RCTs, but the bias differs, very low risk and high risk of bias. Is it clear?
Yes,
Is it
sir.
clear? Yeah. Okay.
Yes,
Now
yes, sir.
let's come to the 2 plus plus, 2 plus and 2 minus. We had RCTs here, so we will have case control and cohort studies. Okay, here. So we will have high quality SR systematic reviews of case control and cohort studies, or high quality case control or cohort studies with very low risk of confounding, bias or chance, and high probability that a relationship is causal. Okay. So what we have here, we don't have RCTs, we have case control or cohort. Okay, they are high quality, but we know in the that pyramid, the best are the RCT, followed by these particular case cohort and case control and cohort. Okay, so here we have high quality systematic reviews are there, but involving mainly case control and cohort studies, but there is a very low risk of confounding or bias, and there is a high probability that the relationship is a causal. So likely to be high possibility of causal relationship. Now let's come to the 2 plus. Here again, what we will have, the case control and cohort. However, the risk of confounding bias will differ. Okay, so they have a low risk of confounding and bias. So well conducted case control and cohort studies with low risk of confounding, bias or chance, and moderate probability that the relationship is causal. Okay, these are 2 plus. Okay, so understood the difference? Here case control cohort, very low risk of confounding, here low risk of confounding or bias. Here high chance probability that the relationship is causal, moderate probability that the relationship is. Now coming to the 2 minus. In 2 minus, again we have case control or cohort with high risk of confounding, and significant risk is that the relationship is not causal. So it is not giving any causal relationship to that particular factor. Okay, so in 2 minus, again we are dealing with the case control and cohort. There is a high risk of confounding and bias, and the relationship is not causal. Okay, that is how this 1 and 2, then either plus 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 or minus you should remember. Is it clear to you?
Yes, sir.
Yeah. So now how to remember? 1 plus plus, best quality RCT and MA with very low risk of bias. Here again RCT and meta-analysis, good RCTs and meta-analysis, low bias. Here it is poor RCTs, meta-analysis, high bias. Okay. Now coming to the this 2 plus plus, these are case control and cohort or observational study, but they are best. Okay, and very low risk of bias, likely causal. Here probable or the moderate possibility of the causal, but the bias is low. Same case control cohort. Here it is poor observational, means case control and cohort, high bias and unlikely causal. Okay, 3 and 4 we remember easily. These are non-analytical case reports and case series, and this is expert opinion. So that is how you should remember these particular study. Okay, so just we'll have these 2 questions. If you can solve these 2 questions, give a try.
Yes, sir. A guideline recommendation is supported by well-conducted meta-analysis, systemic reviews of randomized control trials or randomized control trials with a low risk of bias. What level of evidence best fits this? This is 1
Yeah,
plus.
correct,
1
correct.
plus.
If it would have been 1 plus plus, then what would have been changed here?
It will be high quality meta-analysis, and it will be very low risk of bias.
Correct, correct. Okay, so these keywords you should remember. Next, go ahead with the next.
A recommendation is supported by high quality systemic review of case control and cohort studies, or high quality case control cohort studies with very low risk of confounding bias or chance and a high probability that relationship is causal. Level of evidence is 2 plus plus.
Correct. So what features? First thing, we are dealing with the case control and cohort.
High
They are
quality.
high quality.
High
Okay, and
quality, very low risk of
very low
confounding interest,
relationship
and high.
probability, high probability. Okay, so these are the keywords we should be able to pick up and then analyze. Okay, so when you look at these answers now, we are likely to get confused. So whenever any EMQ you are solving, when you read the stem, at that time you should understand, or you should have the probable answer in front of you, then search for that option and then see is there any other best option apart whatever you have selected. Is that right? Have you understood the
Yes,
way of solving the EMQ now? Okay, so you should
yes,
come
sir.
don't look at the answers first. Okay, so that finishes the today's topic. So correct answer for the first is B, then it is answer B. Okay, so that finishes today's topic. Thank you.